Hey guys, welcome back to my channel. Thank you so much for watching. Really, thank you so much. Last week I wasn't able to upload a video and I'm sorry that I did not because I just simply couldn't. We had a power outage in my neighborhood. There was a tropical storm that ran through here and downed a bunch of trees, and then we ended up without power for most of the week, Tuesday to Saturday. No power. 3 kids. Middle of a pandemic. We made it through, but it was a challenge, of course. But here I am back at it, and so I wanted to come back at you guys with a video that I think you guys will love. This is going to be a reaction video. So I'm reacting to a suggested video based on the comments from a subscriber, Salon Sare. I hope I'm saying your name correctly. Thank you so much for your comment and your suggestion. I thought this was great. So this is a video of someone who is undergoing general anesthesia, and it shows the process from which they are awake and get medications, and then they get intubated, and all of that is shown on the screen. So I think this is a great video to show kind of what happens generally when people go to sleep. It's not the normal. So Salon, your question was, you saw this video, you were horrified, rightfully so, and you wanted to know, is this the norm? Is this something that typically happens when people are going off to sleep and, when we're intubating them? And the answer to that is no. This is not typically what happens when a patient is coming in that's otherwise healthy and is going for an elective procedure. This is generally not the way that you go off to sleep. This patient in this scenario was undergoing a surgery, most likely to remove a cancerous mass in her mouth. So the video is called Anesthetist Administers General Anesthesia, and the description says that this is depicting the induction and intubation, or it's basically depicting how a patient would go off to sleep in this setting, and this particular patient has a cancerous mouth mass. Okay, so already when I heard that and I read that, and I was thinking, in this type of patient, I know what I would be worried about, my patient-specific concerns as far as what would happen when they go off to sleep and when I'm putting the breathing tube in. So I already know, I already kind of had an idea of what I was gonna see even before I watched it. And yep, that's what was shown there. What you're gonna see is basically what we call an awake intubation. That, my friend, does happen when absolutely necessary, and I'm assuming in this case it was absolutely necessary. So what normally happens? Not that. Usually people don't get intubated while they're awake. We usually make sure that you're nice and fully off to sleep, comfortable as ever, unaware as ever, before we put the breathing tube in. And that's accomplished by a number of drugs, and usually it's our cocktail of induction. So what is induction? Induction is when you go from this state of being fully awake and aware of what's going on around you to a state of being completely unconscious, imperceptible to stimuluses, sounds, visual input, all of that gone. So how does this happen? Usually we give medications that all work together to get to this common goal of unconsciousness and unawareness. And those medications are typically starts off with a medication that's similar to Ativan or Xanax called midazolam. Very short-acting medicine, and the main goal of that medicine is to relax you, calm you, especially if you're nervous. You'll get this early. And another thing that it does that's really great is that it makes you amnestic, or you forget, you have amnesia of all the things that happen afterwards, especially the thing that's happening in this video, which is the intubation. So we usually give that pretty early. It acts very quickly. It's about 2 minutes till onset and about 5 to 10 minutes to its maximum effect. And then after that, you don't remember anything else of that intubation and the subsequent surgery, and maybe the things that happen while you're waking up and in recovery. So a lot of people don't have good memory of that. So if you're gonna have surgery, you're getting this medication pretty early, typically, and that's gonna help you kind of have a really blurry, if no recollection of what happened during the day. Another medicine we give in the cocktail that I've actually done a video on is fentanyl. And so fentanyl is really helpful with getting people off to sleep because it helps to reduce or blunt or ablate your response to the intubation. So it makes it very smooth. Things work out, you know, pretty quickly, and you don't have complications and side effects that usually would happen if you don't give that drug. You know, oftentimes when we're putting the breathing tube in, it can really cause people with like a higher excitability to have like a high heart rate, their heart rate's beating fast, their blood pressure pumps all the way up to the sky. Those are things that are really not good side effects of us intubating. So we like to give fentanyl in addition to help reduce that response, to kind of blunt it, to smooth it out so that everything is really nice and controlled and you don't get all those side effects. So it's really helpful and very short acting, and it doesn't linger in your system very long afterwards when we give that first dose. The next drug that we give, and this is the real heavy lifter, this is the one that's gonna really get you from being like fully awake to an unconscious state, and that's what we call our induction agent. So the induction agents that we typically use are propofol or intimidate. So these two meds, propofol, you guys may have heard many times before, and that's another drug that I've done a previous video on that you can check out. And that drug is very typically a white substance that is really easily recognizable. It's the milk of anesthesia, some people call it. It's a white substance that we give to get people off to sleep, and we usually give a pretty large dose of that medication to help people get off to sleep rather quickly. So that medication works super fast, within seconds. So some people feel the effects even within 30 seconds of us giving it, and that's why you kind of don't remember, like, you know, what happened after the anesthesiologist put that mask on your face and they told you to count down or take a deep breath. The next thing you know, you were like talking to your mom in the recovery room and sipping on some cranberry juice or whatever. So that drug works really fast and it's super effective. The other drug I mentioned, etomidate, is another drug that you can give to get people off to sleep that works also really fast. The major difference with etomidate is that you don't have as much of the blood pressure drop that you might see when you give a lot of propofol to get people off to sleep. And that's really important when people have conditions of the heart where it's really dangerous for them to have a drop in their blood pressure. So that's a drug that we often reserve for those situations or patients that are a little bit unstable, because because it tends to be safer in those scenarios. And then lastly, in the cocktail of medications, we'll give what we call a muscle relaxant or a paralytic, as it's also referred to. So these are drugs that relax all of the muscles of the throat, specifically the vocal cords, because that's where we're going to be placing the breathing tube through. So we want to make sure that the vocal cords are open. They're usually like this and they reverberate when you speak. So what we want for them to do is be open like this, totally open, so that the breathing tube can go through the space between them and not really disturb them or injure them. So a muscle relaxant is very much helpful to facilitate a smooth and safe intubation that doesn't cause any trauma or injury to your vocal cords or your throat. So that's our cocktail generally. It's about 4 drugs. So I said midazolam, fentanyl, propofol or etomidate, and then a muscle relaxant. So that's 4 drugs. So we usually give that cocktail to help smooth out and give a very controlled induction of anesthesia and allow for a really ideal and optimized intubation. So that being said, that's not gonna happen here in this video. So you guys will watch what's going on, and I'm gonna try to explain to you what I believe is given and what's happening at each step of the process. And then what's commonly seen in a lot of like depictions or dramatizations of like someone having surgery or undergoing anesthesia is that mask coming over their face. Like you see the perspective of the patient and then you just see the mask coming down. And most people think that that mask is like, oh, they're going out, that mask is putting them out. Really, it's not that. That mask is the way that we deliver 100% oxygen to help prepare the lungs for the intubation process. So as you know, as I just described, we usually give a cocktail of drugs, and then after that, we intubate. So during that time frame, while we're giving that cocktail of drugs and you're getting sedated and really sleepy, we want to make sure your lungs are full of oxygen and ready and prepared for the intubation. Usually there's a time frame between when we give that induction drug, the propofol, and when the breathing tube goes in. So we want to make sure that we're giving you oxygen, that we're actually ventilating or breathing for you, and that will help us to maintain that oxygen level while we're waiting for the muscle relaxant or the paralytic to work to open up your vocal cords. Okay, so that's what's going on. That's really what's happening when that oxygen mask goes on the patient. So once that mask goes on and we ask you to count backwards or like take some deep breaths, and then next thing you know you're out, that's what's really going on. So it's oxygen and usually not anesthesia. Of course there are other cases where that mask is used to give anesthesia, like if you're at the dentist office or if you're having a procedure that requires you to inhale anesthetics and maybe it's a really brief, quick procedure so that you don't get intubated. So those are those situations, but usually it's not. It's usually just oxygen. So that being said, I think we can get into this video finally and check out what's going on in this scene. So a disclaimer for anyone who is very sensitive or, you know, maybe easily triggered by images, you know, sensitive stomach, may react, you know, have a strong, if you have a strong gag reflex, if you have a really sensitive stomach, you may want to, like, you know, think before you watch the rest of this video, because I don't want you to be triggered, but, you know, by all means, just, you've been warned, and let's get into the video. Okay, so again, this is Anesthetist Administers General Anesthetic, and it is a part of the ApprenticeDoctor.com video collection. Okay. So the very beginning of the video, so the gentleman in the back is the anesthetist, and he is prepping the patient. The patient was breathing oxygen, so that's what's being held over her face by the woman in the video. So she is holding the mask of oxygen while the anesthetist is getting all the things ready that they need. And I see that the patient like has her hand on the mask and the anesthetist brings it down like, okay, relax, we don't need your help to participate in this, it looks like. So yeah, that's probably what's going on there. Could have done it a little more gently. And then my other critique, just because I have to critique, I can't not critique, why aren't they wearing masks? I'm wondering, I know this is not COVID times. This has to be like pre-COVID times. And like, obviously when you look back at the description and when it was published, it's certainly pre-COVID times. But why aren't y'all wearing masks? Masks were a requirement, a standard precautions in the OR. It's not even like, you know, going above and beyond. When you're in the OR, you wear a hat to cover your hair because you don't want to shed your hair into the sterile surgical field or in the OR, which is considered a clean environment. And you wear scrubs as you're wearing because you also don't want to bring in like outside dirt, lint, etc. And also you don't want to soil your clothes because that could happen. And then you wear masks because you don't want your droplets to go into the patient's mouth and you don't want the patient's droplets to become aerosolized and go into your mouth. So usually that's what happens. So I don't really know all the details of this scenario, but all I know is that she ain't wearing gloves and he ain't wearing a mask. And neither of them are wearing masks. Like, what is going on? Anyway, so let's just keep watching and let's just get into the context of the video and just learn from them. Okay, so the patient's breathing oxygen and that tubing is going back to the anesthesia machine. That's the circuit, and that's delivering the oxygen to her. 100% oxygen typically. And you can see she's breathing spontaneously on her own. So no one's assisting her. And my assumption is that he wants to keep her breathing on her own throughout this process because that's safest in this scenario. Okay, so he's bringing over a syringe of a white substance. So again, that's the propofol. So he's giving her a very small dose of it. As you can see, it's just like a little bit in the syringe. So that's a much smaller dose than we would typically give you if you're coming in and you're, you know, otherwise healthy and we're putting you off to sleep. So I'm thinking he's giving her a very small dose because he wants to keep her breathing on her own, as large doses of propofol are known to cause apnea or make you stop breathing, and that's the problem with giving large doses in an uncontrolled environment, i.e. an environment where someone can breathe for you, like in the hospital, in the OR. So he's giving her very small doses of propofol to titrate it in so that she can still maintain her drive to breathe. However, she can become more sedated and allow for him to do the intubation. So that's what I'm thinking is going on here. So usually we would give you like a huge syringe of that. He's just giving a little bit. Yep, so that goes into the IV. And every patient that's getting general anesthesia should have an IV. So he's just prepared a laryngoscope. So you see that there? Let's pause that there. So he has a laryngoscope in his hand. That's that metal device, that handle with that blade on the end. That's a laryngoscope, and that is what we use to allow us to see your vocal cords, basically. So we have to go around, lift up all the other structures in the mouth, get the tongue out of the way, and then we can see your vocal cords and put the tube between them. So before he puts this laryngoscope in her mouth, her eyes are wide open. She looks a little scared to me. You know, yeah, so let's see what happens. Ooh. Okay, so there's that gag. So that, you know, basically told him, you know, she's not ready. She's not ready for this intubation. She has to be a little bit more sedated, maybe a lot more sedated. And, you know, we have to give some time for the medicine that he gave, the bit of propofol to maybe work. Because he injected it into the IV. Seems like he waited a little bit, but maybe he needs to wait a little bit longer. So again, typically it takes about 30 seconds and can take up to 60 seconds for you to really see the effect of propofol. But if you're giving a small dose, you may not see like a profound effect. So he's waiting, giving more oxygen during that time frame so that she can maintain that high level of oxygen in her lungs, and then probably gonna try again. Yep, so he went to the back and he's now gotten another syringe worth of some clearer medication, which if I had to guess, I would say this is probably fentanyl, or it could even be ketamine, which is another great drug I didn't mention that you can use for induction. And the good thing about it is that it doesn't make you stop breathing as much as the other drugs that we give for induction do. So in someone you want to keep breathing spontaneously, that's another good option. So they're checking her. She looks more sedated. And then here he comes again with more propofol. So he's giving another bolus dose of propofol. Not too much. Notice he didn't give all of it because again, he wants to keep her breathing spontaneously, I think. So with a little time, she looks more sedated, and then he's gonna try again. So let's pause there. So as you can see, she has the laryngoscope blade. He's going to be placing that in the mouth. He's holding that with his left hand. And then in his right hand, he's holding the endotracheal tube or the breathing tube. So that is ready to go, and he's prepared to place that into the patient's mouth as soon as he gets a view with his laryngoscope blade of the vocal cords. So let's see how this goes. All right, she seems to be still moving a little bit there, but not gagging as much, which is good. All right, that hand went up. Oof, so already knew. Not ready yet. So, you know, she's responding a little bit too much to the laryngoscopy, or the movement of that blade into the mouth to look at the structures in there, and so she needs to be a little bit more sedated. So he's gonna pause on his second attempt and then maybe give her some more drugs or maybe some more time. Let's see. Okay, so yep, coming back with that propofol, giving another dose, and someone puts her hand out. Oh, I hate to see that. But her eyes are closed now, so that's good. She looks more sedated. All right, so here goes the third attempt. So he's positioning her head. He puts that blade in. She doesn't respond. The blade is all the way there. He's getting a view of her cords. And he's bending that tube to make sure it's in the right curvature to get right before the cords and through them. And then he's in. And that's it. He connects it. And he checked the machine. It looks like it's good. And now they're securing it. As you can see, the patient's coughing a little bit, but that's okay. That's all right. That's okay. And the video ends there. So, you know, that little bit of coughing is normal. It happens. Especially, I'm assuming in this setting, he didn't use any muscle relaxant. Again, he wants to keep her breathing spontaneously in case that lesion in her mouth is like gonna obstruct or block her breathing path when she gets a relaxant. So, you know, he really, you know, wants to be cautious, and he's putting this tube in the safest manner, I believe, you know, he feels is possible to ensure that, you know, there's no complication, that she doesn't have, you know, a blockage of her breathing before he can get the tube in. So that's why she coughed afterward, and usually patients don't, because we give them a muscle relaxant so their body is totally relaxed, totally not moving. Okay, so you guys watched that, and hopefully it wasn't too disturbing to you. So I've definitely seen, like, through my peripheral vision, medical students like hit the dirt, like, you know, eat dust in the OR, you know, during the intubation, because it's like, oh, what's happening? I think it's a really like shocking thing to see for the first time. So I totally understand like why the reaction would be that way to that. So just know that, you know, that whole process of, you know, looking in there with that blade and, you know, having to put a big metal object in someone's mouth in order to intubate them is kind of normal. It's kind of the standard procedure, like straightforward intubations. Of course, we can use a lot of different techniques and other equipment, like different video laryngoscopes and different devices that allow us to see indirectly. We can look on a camera screen and see what's going on in the mouth. We can use fiber optic scopes. All these different tools and gadgets are available, but usually, standardly, we use this big metal scope and, you know, put the blade in someone's mouth, lift up, and then place the breathing tube. So it sounds gory and medieval, like, but this is what we do. This is what you're gonna do, and this is what you're gonna do when you're training to deliver anesthesia. And this is what you're gonna experience, hopefully not perceive, when you're having general anesthesia for your surgery. So just know all of that is standard procedure, and the difference is you're gonna be asleep and your patient is probably gonna be fully asleep when you're doing it, so it's gonna be a lot easier and a lot more straightforward. And this whole technique is something that you have to do a bunch of times to get really good at. So if you're just learning for the first time, or, you know, you're just starting off your rotation in anesthesia, or your intern year, or, you know, your residency, since it's the beginning of the year, technically it's the beginning of the year still, just know it's gonna take you a whole bunch of times to get and perfect that skill. Don't get down on yourself if you're not getting every single one every single time. Most people actually have there's a steep learning curve. It actually takes most people many tries and, you know, all of their career to really perfect the art of intubation. So don't get down on yourself. So that being said, I really hope you guys enjoyed this video, the reaction to this video as well, and learned a lot about like what really goes on when people are going off to sleep and getting general anesthesia. Let me know if you want to see more on this topic, and I will definitely get into the nitty-gritty, in-depth details. Yeah, so please leave your questions and suggestions for future videos in the comments, and I will do my best to bring you guys content that you're looking for and to answer those questions that you've been having about anesthesia. And with that, I thank you guys so much for watching. Please take care of yourself, be safe out there, and until next time,